Hello and welcome to tonight's panel discussion sponsored by MidLantic Urology on men's sexual wellness. We are very excited to be here. We have a panel of really wonderful doctors with lots of experience and interest in men's health and specifically men's sexual health. So I invite everybody to this very open, casual, but instructive and didactic format in order for us to all learn and hopefully get some more information, answer some questions about men's sexual wellness, sexual health. I'll briefly introduce myself, and then I'll have Dr. Bernstein and Dr. Sterling introduce themselves. I'm Cara O'Brien. I'm a general urologist. I work out of the media office. I have a really strong interest in sexual health, testosterone therapy, vasectomy, erectile dysfunction, all of the topics we're going to hit tonight. I love teaching. I love engaging with patients. So it's really exciting and an honor for me to be here to help all of you. Dr. Bernstein, do you want to say a few words?
Sure. Good evening. Guy Bernstein. I'm a urologist with offices in Bryn Mawr and Paoli, and been involved with treating men's wellness and health for 37 years now. Again, covering most of the areas that we're going to talk about this evening. So welcome, and we hope this is informative.
Matt Sterling, also urologist in Bryn Mawr. Similar to the others, really have a passion in men's health, mostly benign urology, erectile dysfunction, Peyronie's disease, amongst others. So really excited to have everyone.
Thanks, team. All right. So just a brief overview. Why talk about sexual wellness? Well, because this affects everyone. I really believe that this is a couple's disease. So when we are treating one patient, we're actually treating two or more, depending on their partnership, their couple. And so managing your sexual health is really important. It helps protect your physical, your mental, and your overall well-being. We're going to talk in a couple of different slides about how sexual health is really a very good and early indicator of overall general health. So if we can optimize sexual health, we're optimizing overall health. People talk about lifespan. People also talk about sex span. So really important part of mental and physical well-being. Just to give you some statistics, there was a 2019 study out of West Virginia University. It really highlighted the fact that men are perhaps more shy or less willing or able to talk about sexual health. And so we really love these sorts of open and anonymous forums to help encourage and open and start the conversation so that you can kind of have a little bit more to talk with your urologist, because we're all here and we love talking about this sort of thing and want to make sure that you feel heard and don't feel afraid. So speak up, because it's something that a lot of men are dealing with, and it's something that we want to be able to help you with. More statistics, a 2023 Cleveland Clinic study, 44% of men are worried about erectile dysfunction. There's a lot of statistics out there. By the age of 40% of men will have some element of erectile dysfunction, 50% of men at 50, so on and so on. So again, these are really important topics that affect a lot of patients and a lot of people. And again, not just the man, but also their partner. 39% of men are worried about loss of sex drive. We're going to talk about that in our testosterone replacement or our testosterone therapy discussion. And then 36% of men are also worried about a low testosterone. Again, these are really common topics, affect a lot of men, and you've got experts here who want to help. Quickly, what we're going to discuss tonight, a couple key points or topics: low testosterone, Peyronie's disease, premature ejaculation, vasectomy, infertility, and erectile dysfunction. So without further ado, I'm going to have Dr. Bernstein lead off our discussion on low testosterone.
Low testosterone is a very important condition that we see, and more men are coming into the office now, either inquiring about their testosterone levels or have already been referred because they've had their primary care physician or other caregiver obtained a testosterone level and found that it's low. So I'd like to review with you a little bit about low testosterone, the symptoms, and also some of the treatment options. Let me go forward. So there is really a laundry list of symptoms that can occur with low testosterone. The most common we hear about really relate towards fatigue, lack of energy, loss of libido, sexual performance issues, but there are other issues that come up as well: loss of muscle mass, gain of fat and weight. Some people describe having a mental fog that they think relates to their low testosterone. Obviously, at the extreme, you can get hot flashes, just like a woman going through menopause. But clearly, it can give also some depressive affect and depressive thoughts. So although it can happen at any age, I would say in general, it increases as age increases. It's very interesting now that it's been associated with diabetes, with elevated cholesterol, high blood pressure, and obesity. So all the common things, as we talked about at the beginning, how these things can relate to your general sense of well-being and may, in turn, actually raise the question about, are there other issues that should be addressed as well as just your low testosterone? As we said, it's not just for sexual health. It can affect bones, cardiac, mental, and psychological well-being. There are really a couple things to know about testosterone. First of all, there's a total testosterone and there's a free testosterone. The free testosterone is the portion of testosterone most active. And some men will have a normal testosterone, but actually have a low free testosterone, which could also still impact on a lot of these issues. Also, testosterone has a very wide range, and there are a number of different tests with different ranges. So when you hear a number, it really reflects a little bit the range of the test that you've been that's been obtained. We as urologists are very, very experienced, although there are a lot of other avenues to obtain testosterone online, through testosterone clinics. Really, as urologists, we've been dealing with this for as long as we've been in practice. And it's very important, as I said, that it not only reflects just your sexual issues, but also can relate to other health issues as well. And there are a number of ways to replace testosterone. You can do it with gels. You can do it with oral medications. There are 3 of them on the market right now that are FDA approved. There's a nasal spray, there are patches, there are testosterone pellets that can be placed, and there's obviously testosterone injections. All of these can be obtained either through your insurance, but also sometimes, depending on insurance coverage, can be also obtained as compounded or through other avenues. And again, as urologists, we can help navigate. One thing that's very important is that in many situations, it can be covered by insurance. And some men who come to see us in our clinics don't realize how much they're paying out of pocket to get it online or through a testosterone clinic that's not a urology specific, and they're paying out of pocket for things that we could get covered potentially with their insurance. Again, once you're on a testosterone therapy, it's very important that you get monitored, both to see how well you're doing with your testosterone level, but testosterone has some other impacts. We want to check your hemoglobin or your red blood cell count to make sure that it's not significantly elevated. And although it does not, and I repeat, does not cause prostate cancer, it's very helpful for men who are over the age of 50 or appropriate aged for a PSA test to have their prostate assessed and make sure that there's no potential impact on their prostate health as well. So again, there are a number of things that should be tested along the way. I should also mention briefly that when you give testosterone, for some men, certain conditions, their estrogen levels can go up, and it's very important to monitor those as well, because there are ways to modify that impact on estrogen. So again, these are things that we as urologists deal with on a day-to-day basis.
All right, I'm going to take over to talk about Peyronie's disease, or penile curvature. So Peyronie's disease really is a condition that can cause penile curvature. Patients can get an indentation in the penis. Sometimes they'll present with loss of length upon erection. And I really tell patients, most of the time, this is in patients over 40 or 50 that have mild to moderate erectile dysfunction. and they typically will get Peyronie's disease from microscopic trauma during intercourse. That's the most common reason. Obviously, larger trauma can happen as well. That can lead to scar tissue, but it's typically not something that most men will remember. And that leads to scar tissue formation in the penis and then a misshapen penis. So again, either a curve or an indentation. It's really undertreated, although with more advertisements, I would say more patients are coming to the office, which is great. Most studies would show about 10% of men in America have some sort of Peyronie's disease. The most common symptoms I see when patients will present, either they'll have a curve or a bend to the penis, they might feel a lump, they might have noticed some pain with erections, or it can be associated, as I said, often with erectile dysfunction. And it's something we treat a lot, obviously at MidLantic Urology. So some of the treatments for Peyronie's disease. So I typically will start with more conservative management. So I really like Restore extraction therapy as a first step, both in patients that have had it for a while and haven't had any treatment, or patients that present, only with a month of this condition. Studies have shown a 30% improvement in curve and 1 to 2 centimeter length improvement. So I really like this form of therapy. There are some medications such as Xiaflex, which is an injection medication that can break up the plaque. This came out about 10 to 12 years ago. Studies show also about 30 to 35% improvement in curve, although some studies have shown potentially more improvement with if used alongside traction therapy. Obviously very safe and effective office-based treatment. And then there's various surgeries, and it really depends on the amount of curve or misshapeness that patients have. So the most common surgery that most of us will perform is a penile application, where you basically straighten out the opposite side of the penis to help straighten the curve, which has a very nice success rate. About 90% of patients will end up with less than 10 degrees of curve after surgery. For patients with concomitant erectile dysfunction, penile implants also can help correct both curve and erectile dysfunction. And then for the most severe curves, you can do a grafting procedure. Again, all of this should be worked out, with your urologist. Typically, an in-office curve assessment or potentially an ultrasound will help define if there's good blood flow into the penis and can define the amount of curve that you have, and then give you your options. I can pass it back to Cara. Dr. O'Brien.
Great, thanks, Matt. So just to briefly touch on premature ejaculation, the providers and I were all discussing this lecture before this evening, and Dr. Sterling and I really agreed that we don't see this quite often, and maybe that's because it doesn't exist as often, but probably more so because patients are just a little bit more reticent to talk about it. It can be a little bit of a touchy subject, like a lot of these. But really the definition of premature ejaculation is at least several months of persistent or episodic ejaculation that occurs prior to or within a very short duration. Usually 1 to 3 minutes is kind of the time period that we designate of starting of vaginal penetration or other sort of sexual stimulation, and the patient has little or no perceived control over the ejaculation, and most importantly, it's bothersome to the patient or to the couple. So you really have to hit all of those criteria to really truly diagnose premature ejaculation. There could be some medical reasons for it. There can be things like prostatitis, erectile dysfunction, a couple of other medical conditions that may contribute to it. It actually is very commonly seen with erectile dysfunction, interestingly, and we find that if we address the erectile dysfunction, that we see an improvement in the premature ejaculation as well. There is laboratory testing that we can do to rule out other things, as I mentioned, prostatitis, thyroid issues, testosterone issues, etc. But really the core of this, that it's most commonly idiopathic. And that's just a fancy word to mean we don't always have a very good understanding or clear cause of what's causing the premature ejaculation. So we really focus on treatment for the patient. Treatment really centers or starts with behavioral modifications. There are several different techniques which can be initiated during sexual activity. The pause technique, vagina, the start and stop technique, all of them sort of self-explanatory given their name, but essentially ways to kind of extend the arousal period and delay the onset of ejaculation. There are things like delay sprays, and there's a lot of companies, or a couple of good companies that I'm aware of, that have delay sprays that can be used on the penis in order to prolong that arousal period prior to ejaculation. And there are prescription ones too that your urologist can order for you as well. And then off-label, and I think that's the next slide here. Here we go. Yeah, so this is just highlighting all of the things I've been mentioning: behavioral changes, topical therapies. There are off-label medications for premature ejaculation, so there's actually no FDA-approved oral medicines, but we will off-label prescribe certain antidepressants. SSRIs is the common class, serotonergic reuptake inhibitors, that we can prescribe for premature ejaculation. So again, there are some options, and certainly something to discuss with your urologist if this is a concern for you. Let me move on to our next slide. Oops, excuse me. All right, vasectomy, Dr. Sterling.
Great. Yeah, this is something certainly all three of us here perform a lot of, definitely. So I'll briefly talk about vasectomy. Obviously, vasectomies are performed to create sterility. So in patients that no longer want to have children, this is most often performed under local anesthesia with just some numbing medication in the office or outpatient ambulatory surgery center. Essentially what I tell patients is the testicles make sperm and testosterone, and the vas deferens carry that sperm to the fluid that is made in the seminal vesicles in the prostate. And so while we're not touching the organs that can, control the fluid, we're not touching the testicles, you're still going to make sperm and testosterone. We're essentially just blocking those tubes, and everyone kind of does it a little bit differently in terms of how they obstruct the flow of sperm. Typically takes about 15 to 30 minutes. Again, is most often very well tolerated in the office setting. Most patients are sore for a few days. My office, we typically do these on a Friday, typically sore over the weekend. By Monday or Tuesday of the next week are feeling more normal. Most patients are back to fairly normal activity at about a week after surgery, sometimes 2 weeks. Some of the myths. So this, vasectomies don't impact your sexual performance, doesn't impact your ability to achieve orgasm. Your semen to the naked eye should look the same. Obviously, it should no longer have sperm in it. It's not associated with sexually transmitted diseases at all. Reversal obviously is possible. Dr. Bernstein does those. I never go into a vasectomy hoping that we're going to reverse it. So I always try to tell patients this is something you and your partner really want to do, or you want to do on your own. But reversals are possible, obviously, if needed, and situations change. All right, Dr. Bernstein.
Okay, that leads us to infertility. As described, obviously, one of the various obvious causes is if you've had a vasectomy, there are a couple ways to extract sperm. Either you could reverse a vasectomy, or we can actually extract the sperm from the testicle, but that sort of leads towards something like IVF, where again, you might be working with a fertility center as well as myself. Let's go to the next slide. So just a few things about vasectomy. First of all, about fertility and infertility. First of all, you should understand that really nearly 50% of couples, there is a male issue involved, although a lot of times women take it upon themselves to assume that their fertility is a female issue. In fact, because of a number of different factors, could be hormonal, it could be because of blocked vas deferens, it could be because the testicles aren't making enough or adequate sperm or quality sperm, that these are all possibilities as to why men can be causing part of the fertility issue themselves. And you can see the statistics up on the top of the screen that basically describe a little bit of the scenarios. We typically define infertility as a couple trying for at least 1 year of active trying, namely around the time of ovulation. However, as couples decide at different points to start a family, and we oftentimes see older couples being interested in starting a family, the time frame really depends on where their comfort level is. A lot of times it could be 3 or 6 months of trying and there's no success, and then we start to see them. So there's not an absolute number that you have to wait until you really get an evaluation. Any urologist can start the evaluation. Obviously, there's some hormone tests we like to do to determine if there's an issue with testicular production of sperm. There's issues with the history. Was there any problems with testicular development as a child or a teenage year? Is there any problem with ejaculation? Obviously, if you're having problems with erections, that clearly can impact on your ability to have adequate fertility. One of the other things very important are that certain quality of health issues can play a role. We know that excess of heat, excess alcohol, excess caffeine, marijuana use can all have a negative impact on sperm. So certainly those are things that are controllable, and we do talk about behavioral changes that may make a difference. Let's see. So leading on to the next steps, once we've sort of evaluated some of the behavioral issues, clearly a semen analysis is worthwhile. There are a number of ways you can get semen analysis. You can do it at a fertility center. We do have kits in our office that we can send out for fertility testing. The one place I don't recommend is going to a hospital lab. They just don't see a lot of semen analysis to do high quality fertility work. We like to check a urinalysis again to look for other conditions that may impact on fertility, such as diabetes with elevated sugar levels, or if there's protein deficiencies that may contribute. We talked about some blood tests that can help decide whether there's a hormonal issue involved. And then also I should mention that there's something called a varicocele, which are dilated veins in the scrotal sac that can impact as many as 40% of men who have fertility issues. And again, there's surgical correction about that, which again, many urologists are comfortable doing. Sometimes we go so far as to do a biopsy of the testicle because we need to really determine, is the testicle making sperm or is it not making sperm? And if the sperm are being produced, are they of good quality sperm that should be lead towards successful fertility? We talked about lifestyle changes, diet, caffeine, alcohol, exercise, marijuana use. We talked about some of the surgeries. Again, you can reverse a vasectomy. As Dr. Sterling said, when I do my vasectomies, I hope and assume that they're not going to want it reversed. But every so often, someone changes their mind for various reasons, remarriage, children getting older, wanting to have additional children later in life as reasons to reverse a vasectomy. There are, unfortunately, children who have undescended testicles that can contribute. And again, sometimes there can be helpful corrections, but sometimes, again, what's very nice is we have excellent IVF services in our area that help contribute to a couple's desire to achieve pregnancy. So again, a lot of these things can be started with urologists, and then those of us who specialize in fertility can take the lead from there. Erectile dysfunction.
All right, I think Dr. Sterling and I are gonna tag team on this one. I'll just start off by giving some big, broad statistics. So erectile dysfunction, it's defined as the ongoing inability to achieve or maintain an erection that is firm enough to have sexual intercourse. We use penetration as really one of the markers, guideposts for dysfunction. The questions you're probably going to be asked is your erection firm enough for penetration? Before I go further, I want to remind everybody we have an open forum, or we have an open area to submit questions. I'm just seeing some pop up, so I really encourage everyone. This is anonymous. Use our expertise, use our brain power here to ask questions. All right, just wanted to say that before I forgot. 1 in 5 American men will experience erectile dysfunction in their lifetime. I mentioned the statistic previously that I hear a lot at the conferences, which is 40% of men over 40, 50% over men of 50, 60% of men over 60, etc., will experience some element of erectile dysfunction. And over half of men over 50 will have some degree, again, to quote that statistic again. This affects over 30 million American men. Very common. So I love explaining how an erection works, because I think it's really helpful to understand the basics of that, and then helps you better understand the treatments that we use to fix erectile dysfunction. So the way I like to explain it is there's really two important steps or parts, components to an erection. There's the blood flow in and the blood flow out. So the way an erection develops is by blood flow in. That dilation of those blood vessels creates the erection, the firm penis. And the way that firm penis, that erection, is maintained is by blood trapped within the small vessels and the outflow being slowed or stopped so that the erection lasts long enough for a successful sexual experience. So we have to keep in mind those two important steps and how we are trying to address each of those. Really basic flow of how this goes. Arousal stimulates the nerves within the pelvis, the penis. The muscles around the arteries of the penis relax. That relaxation, stimulated by nitric oxide, which a lot of you have probably heard about because there's all sorts of over-the-counter nitric oxide boosters, but that nitric oxide is involved in relaxing the arteries, which increases the blood flow. That's step one. Remember, we said there's two important steps. There's initially that blood flow in. So the additional blood makes the penis stiff, hard, erect, firm. And that erection, that blood flow in, is what compresses the veins so that blood can't come out and the erection is maintained for long enough to enjoy the experience. So two important steps, and that's just kind of the basics, the 30,000-foot view of how it's all working. And having that basic understanding really then gives you a better, understanding of how the erectile medications work and other treatments that we do for erectile dysfunction. So common causes of erectile dysfunction. Well, overwhelmingly what we see is that it's due to just poor overall health. I mentioned at the very beginning of all of this, sexual health, sexual wellness is really a very good early indicator of overall health status. Vascular disease, disease of the blood vessels, diabetes, obesity, smoking, really the biggest contributors to poor health and therefore poor erectile health. My computer is alerting me that my streaming is going in and out. I hope I'm not being affected too much by that. All right, streaming connection recovered. Hopefully, sorry, I hope I'm not going too much off of my streaming to improve connection. But again, overall poor health is the biggest contributor to erectile dysfunction. And then there's other contributors, certain medications, certain pelvic surgeries for colorectal cancers, for prostate cancers. Low testosterone is a potential contributor. Radiation treatments, again, for colorectal cancers and prostate cancers can also affect erectile function. And then psychological components, depression, anxiety. That's a huge component to our libido, to our erectile function. And it's often overlooked. And I think it's a really, really astute patient who comes in and says to me, hey, I think there is a psychological component to my erectile dysfunction. That tells me they're really paying attention to their body, and it's something that I help them work through. So if those are the causes of erectile dysfunction, then what can we do to improve your erectile function and your overall health? Well, healthy diet, fruits and vegetables, an anti-inflammatory diet, very important to things that I stress with my patients. Exercise, really two parts to exercise. Aerobic, we want you burning calories, we want you building cardiovascular health, blood flow, And then the weight training component, where we're improving muscle mass, which improves testosterone and overall esteem. Losing weight is a big part of that. Limiting alcohol, quitting smoking, stress. I always talk about stress reduction, and well, I never say stress reduction because I don't think you can really reduce stress, but there are ways to better adapt your stress response and sort of cope with stress. And then sleep. Very, very important. Lots and lots of men come to see me for both testosterone therapy, erectile dysfunction, and they have sleep apnea. And they just have really poor sleep quality, which is contributing to all of these health concerns. So one of the biggest things I talk about is sleep studies and addressing sleep issues. Dr. Sterling, tell us about the oral medications for erectile dysfunction treatment.
Sure. So now that Cara kind of told you how things should work, most patients have heard of Viagra, Cialis, Stendra, Levitra. These are really medications that increase blood flow to the penis. Obviously, they require sexual stimulation. A lot of patients will ask me, am I just going to have an erection all day? The answer is no. You're going to have an erection when you want to have an erection. It can be effective. I would say probably 60 to 80% of men are going to have, good or controlled erections with oral therapy. It can be less effective, certainly in men with diabetes, with progressive cardiovascular disease, or those that had prostate surgery. While some insurances may not cover it, I will tell you, we can easily find these medications for everyone fairly cheaply. So your urologist should be able to help for that. Most of us will send our patients through GoodRx or other pharmacies that can find this for them. Most patients will take it about anywhere between 30 minutes and 2 hours before intercourse, depending on which medication you take. And again, depending on whether it's Cialis or Viagra, it can last anywhere from 4 to 36 hours in your system, depending if you're taking it again as needed or daily. There's different options that you should work with your urologist about. Some of the potential side effects, patients can get some headache or facial flushing or congestion, potential for blurred vision. The risk of a prolonged erection with Viagra or Cialis is pretty rare. And so that's something I'll talk to people about just so they're aware of it, but it's not something I've really seen in practice, at least with the oral therapy. So this is really where we'll start. So most patients either will come to us sometimes before they've started this and we started, or they've already tried a few of these and then come to a urologist or a specialist to kind of figure out where to go next. So other potential options, I will say the next slide I talk about is injection therapy. That's typically where I go next when patients have progressive ED beyond oral therapy. I'll sometimes talk about a vacuum device. Tends to be patients that are older and long-term stable relationships that I'll talk to this about, just because the type of erection is a little bit different. It can be effective. Honestly, those stats are probably a little high. I would say 50 to 60% of men can find it efficacious. Basically how it works. So most erections, as Dr. O'Brien talked about, you're going to have blood flow into the penis. This will work by basically creating a vacuum that will pull venous blood into the penis. And then once the penis is plump or erect, you put a ring at the base to keep that blood in. So the penis can look a little purplish, can be a little cold feeling. It's just a little bit of a different erection. However, again, for like 60, maybe 70% of men, it's enough for penetrative intercourse. And so this is an option that I will talk to some patients about. Most patients that go beyond oral therapy, I'll do injection therapy. So this has a success rate, I would say probably about closer to 80% of men will have success. We will have patients meet with one of our physician assistants to learn how to safely inject the medication into their penis. The biggest hurdle I find is getting over the mental idea of injecting yourself in the penis. The needle is really small. I don't have many patients that have significant discomfort doing it. The erections, for the most part, last as long as you want them to. The reason we have people come in to learn is you want to safely know how to use the medication, know how to safely titrate the medication to avoid having a prolonged erection, essentially. And we'll have patients do this about 10 to 15 minutes before they want to have an erection. The medications do have to be refrigerated. The shelf life can be a little bit limited, and most of them are obtained at specialty pharmacies. Again, most offices can help you find where to get it. Some of the reasons men might seek alternative therapies, again, minor discomfort. There's about a 5% chance of developing scar tissue or Peyronie's disease or a curve to the penis, about a 5% chance of a prolonged erection, very small risk of bleeding. Some men do progress, obviously, beyond injection therapy, and then we start talking about other options. Something that's on the news a lot or on the radio is low intensity shockwave therapy. So we thought it was important to bring it up and at least talk about it. The whole theory behind low intensity shockwave therapy is that you're using basically shock waves to cause microscopic trauma and new blood vessel formation that will bring more blood to the penis and improve erections. What I often tell patients is, at the moment, this is experimental. So the American Urological Guidelines do not have this in our guidelines for treatment. The other thing I always tell people is that you want a machine that has focal therapy and not radial therapy. So a lot of the providers, Dr. Bernstein talked about, some of these men's health clinics or ED clinics that say you should get shockwave therapy. A lot of them are not the machines that were studied and shown to be somewhat effective. And so you just have to be careful because they can be very expensive and most of them are out of pocket. Studies at this point are very mixed. So some studies will show 30 to 50% improvement. Some will show 60% improvement at about 1 year. And then that starts to fall off beyond 1 or 2 years. So there's really no long-term data at this point. It's an exciting potential new treatment, but it's not quite ready for prime time for most patients. The patients that benefit the most are ones that actually are getting decent erections with oral therapy. So in patients with more advanced disease where they need injection therapy, or potentially you're getting ready to talk about an implant, this is not typically the treatment that's going to work for you. When patients progress beyond pills or injections, then we start talking about surgery, and I'm going to pass it back over to Dr. O'Brien.
Sorry, I had to unmute myself. Dr. Sterling, we had a really good question that came in the chat that I wanted you to answer before we get off of this topic. And it's a question that I get asked in clinic all of the time. I am using oral medications, currently 50 to 80 milligrams of Viagra. Will the efficacy of this medicine decline over time? You want to take that one?
Sure. I mean, I tell patients that it won't. I usually tell patients that their disease typically is progressing. So I often find that patients need more, like a higher dose of medication. I will often have patients combine therapy sometimes. So Cialis and Viagra, that is off label. So I talk to them about that is off label. There's potentially higher side effects. But when people come and they're like, I've gone on Roe or Hims, like most of those are just Viagra and Cialis combined. And so it's acceptable as long as you understand the risks are a little bit higher and it's off label. But I don't feel that their body's getting used to it. I just think their disease is probably progressing. At least that's what I tell them.
I agree completely. That's exactly what what I do say to patients. It's really the disease, it's not the medication. And there's some other little tricks and cocktails of pills, medications for erectile dysfunction that we can work on. All right, let's jump to surgical management of erectile dysfunction. And I brought props. So there are two very common types of penile implants for erectile dysfunction. The first and kind of simplest, most straightforward to explain is the malleable device. All this is 2 rods placed within the erectile tissue of the penis. And when you want to use it, you direct it outward. And when you don't, you can either put it up towards the abdomen, towards the belly, or to the side of your leg. Very straightforward. It's easy to implant from a surgical perspective. Very quick recovery. Usually you can start using the device within 2 weeks. And there's really no learning curve to it because it is just so straightforward. The other option for devices is a 3-piece malleable prosthesis. This is actually the more common device that is implanted in men. And the reason for that, despite it being a bit more complicated, is the sense that this is a, quote, more natural erectile function. And that's because the device can be flaccid or floppy. And when an erection is desired, a pump, which is placed in the scrotum, is used to inflate the device. So what happens is there's a reservoir of fluid that sits in the lower abdomen, and that fluid is displaced from the reservoir into these cylinders with the pumping, and that creates a firm, rigid penis for penetration. So two options, or two most common options, the malleable and the 3-piece inflatable. Both have their merits, both worthy of discussion with all patients to really see which would be best for you. I have some men who have very strong feelings one way or the other about which device that they want implanted and which one is going to work best for them. Risks of any sort of surgical procedure, implantation of any foreign body, is the risk of infection. That's really the biggest one that we think of. And we give you lots of antibiotics in order to decrease that risk. And in general, that risk is very, very low, less than 3% or so in a lot of the major recent studies. Surgical risk, anytime we're taking someone to the operating room, giving them anesthesia, manipulating their body tissues, there is some risk. And then the risk of device failure. So there's different things that can happen, especially more with the more complicated 3-piece device where there can be some device malfunction. If that occurs, which again is pretty rare, if that occurs, we are able to swap out or replace any of the parts that are defective in order to reimplant and give a man a successful or a device that is helpful and useful. So that is surgical management of erectile dysfunction. All right, so that really summarizes our teaching or our didactic component of tonight's session. We've gotten a lot of great questions that have come in through the chat that I want to summarize and have our experts here go over and answer. A couple of questions that came, I'm going to direct these to you, Dr. Bernstein, a couple that are in regards to testosterone replacement therapy. So one gentleman writes, family history of prostate cancer, would this indicate not using testosterone replacement therapy? I think that's a great question. I have strong feelings about this, so I'd love to see what your reaction is. Another just question you could, kind of ties into that is, why isn't testosterone tested normally like a CBC as part of a regular PCP exam? So why don't you take this?
Yeah, I'll start with the second question first. So we are seeing more and more men getting testosterone checked. Most of the time it's because they're asking their primary care physician as part of their annual screen to check for testosterone. I think one of the good things that have come up because of more conversation about testosterone is men are starting to understand that it is a reasonable test to get as they age. A lot of times men come in and their testosterone levels are borderline low, and it's always problematic to know whether their testosterone levels were always low or whether this is a new change. And so I think when people start getting annual blood screening, whether it be for their, hemoglobin, their white count, their kidney and liver function studies, it's not unreasonable to get a testosterone level as well. I mean, in the past, it was oftentimes just obtained when someone was complaining about erectile dysfunction, but now with all the other symptoms that have been associated with it, very important, I think, to get a baseline testosterone. In terms of the interaction between testosterone and prostate cancer, we do know that testosterone therapy does not induce prostate cancer development. It doesn't take a normal prostate cell and make it malignant. Although there's a little bit of debate, most studies have shown that men, even with low-risk prostate cancer, there's a number of men now who have very low-risk prostate cancer that are on what we call active surveillance. We're not treating them, we're watching them. That giving them testosterone therapy does not increase their risk of disease progression. We also know that men who have been treated with prostate cancer with surgery, radiation, or other therapies can go on testosterone therapy safely Again, it's important to monitor. I will tell you personally, I usually like to wait a year or two to make sure that their cancer is well controlled or cured before I start testosterone therapy. But again, with your question about family history, I think as long as someone's monitoring your PSA as we would normally for any man who has a family history of prostate cancer, and maybe starting a little bit earlier than the average male, that it's reasonable to consider testosterone therapy. One thing that's very important is you really want the testosterone therapy to keep your testosterone within range. Too often we see guys coming in with super physiologic doses of testosterone way above the normal range, and that's not healthy. First of all, it can permanently decrease the size of your testicles, and unfortunately we see that at times, and it's also not healthy in terms of many other impacts that would not normally occur if you kept your testosterone level within the range, which is ideal. So I don't know if you, Cara, or Matt have any feelings about giving testosterone therapy with prostate cancer, but I don't have a problem.
That was beautifully put. I would echo everything that you said. I think the overwhelming understanding now of prostate cancer and testosterone therapy shows that there's really no direct correlation. And so, yes, I think more and more providers with that information are starting testosterone replacement therapy, either going into surgery for prostate cancer. A lot of providers will say, well, I want my patient, sort of euhormonic, meaning at safe or at normal hormone levels. And that may include increasing someone's testosterone and then starting it safely after their treatment. There was a question directly to your point. You actually answered it without even being directly asked, from a gentleman who had therapy for prostate cancer and completed it in 2023 and was asking about testosterone replacement therapy. And I hope he was listening, because you answered his question very eloquently without even being directly aware of the question. So great. Yeah, that sounds perfect. Matt, Dr. Sterling, question about Peyronie's disease. Should I get my Peyronie's disease corrected first before addressing my erectile dysfunction? Intercourse and ejaculations are painful now. Please advise.
Yeah, I typically treat both at the same time. So it really first depends on what process the patient is or what part of the process they are. So Peyronie's disease has an acute or active phase, which is typically the first 9. Most patients are 9 to 12 months. Some go a little bit longer than that, where the main goal is really decreasing inflammation in the penis. I'll do traction therapy, as I talked about. We don't really do definitive treatments such as surgery or Xiaflex typically during the active phase, just because it is changing. Usually we like to see some stability, at least for a 6-month period. So I will often work to improve erectile function at the same time I'm working to improve someone's curve. I like to prove that someone can get strong erections before fixing their curve, because if someone can't get an erection and I fix their curve, in the operating room, that hasn't really helped them if they can't get an erection. So it's really a 2-part process. You want to fix really both and treat both at the same time, because if you're doing more and more for their erectile function and they can't get an erection, now we might be talking about a penile implant instead of a surgery or fixing their Peyronie. So the answer really is you're going to treat both at the same time.
Dr. Sterling, other questions for you. Any idea what is the typical cost of penile injection therapy? And how safe and effective is the use of a penile veno-occlusive ring, veno-occlusive device?
Yeah, so it depends how much you're injecting. So typically these will come in 2.5 milliliter, 5 milliliter vials. I believe the pricing is around $120 to $150 per vial. Keep me honest if that's not true. It depends how much you're injecting. So if you're injecting 0.1 milliliters, you could get a lot of usage out of a small vial. If you're injecting a lot more, then obviously you're going to get less usage. So it really depends how much volume you're injecting. I will say for me, if someone has to start injecting 0.4, 0.5 milliliters, I will increase their dose so that they start to inject less, because it can get pretty costly if they're injecting that much volume. And then in terms of a penile ring, yeah, penile ring certainly can be beneficial in patients with veno-occlusive disease. I know Dr. Bernstein does ultrasounds, and you can kind of see if patients have arterial issues or veno-occlusive issues. I will sometimes add it on. I prefer, there's these, I honestly sit with my laptop with patients and Google with them a penile constriction band, and there's really cheap, good ones that are silicone that have handles on the end that I find safer. I don't really support like metal rings or anything that have the potential to get stuck and there's no out. And so there's some good silicone bands. I usually tell patients to take it off after about a half hour. But I've had success with that. It's just really working with patients and trying to identify, is the main problem blood flow in? Is it blood flow out? Is it a little bit of both? With Peyronie's, you often see more veno-occlusive issues. And so, yeah, it's just something that you'll have to work with, your urologist and kind of go through some of the things you've tried and potentially get creative about how you can help someone, have pleasurable intercourse. Because that bottom line, like, we just want you to have pleasurable intercourse with your partner, or get a good erection and do what you need to do.
I can just add what Dr. Sterling was saying, the Doppler ultrasound, one of the values, because a lot of times it really doesn't help, especially if you respond well to an oral medication. But sometimes if you're really trying to decide if this is an arterial problem or a venous problem, that's where the Doppler can sometimes help. And clearly, if it's a venous problem, especially a significant venous problem, that's where injection therapy doesn't work terribly well. Certainly, the shockwave therapy has almost no value if there's a venous leak syndrome associated with it. If you can get by with a ring, that's great. But then again, that's where all of a sudden time to start thinking about an implant or some other means of correcting it. You can't go so far as to do injection and a ring. And again, I would agree with Dr. Sterling that you want one that's easy to remove, because you don't want to be at risk and you don't want to leave it on for too long, because that can compromise arterial flow in as well.
Dr. Bernstein, while we have you, a question about, is it possible that exercising could increase levels of testosterone?
Yes, it's definitely weight loss and exercise make a difference. And actually, it's sort of becoming very interesting with the GLP-1s now in the marketplace and people losing a lot of weight. And hopefully they keep the weight off by adjusting their diet and exercising as well. It'll be interesting to see if at least some of the testosterone problems dissipate as guys start losing weight and focus on an exercise routine. So those are the two of the things that I say you can take charge of yourself. There's no question that can be a benefit.
Excellent. One question came in about recovery time for implant surgery. And I'll answer that one. And I'll start by just saying it varies on which type of device you have implanted. So generally, kind of broad strokes, I would say about a 2-week recovery time for the malleable penile prosthesis, and a 6-week recovery time for the 3-piece inflatable device. Another question just came in. If you have had your prostate removed, should you go on testosterone treatment before having an implant done? Kind of a complicated question there. And that's something I would really direct you to your urologist for, because we're talking about a couple of different things there. We're talking about why you had your prostate removed, which I assume is probably prostate cancer, testosterone replacement therapy, and erectile dysfunction. So 3 complicated topics there that's probably best to tease out with your urologist. But certainly they can go through a timeline for you that would be useful and beneficial for you. Another question came in that really the gentleman was prescribed tadalafil more for lower urinary tract symptoms than for erectile dysfunction. And it sounds like he noticed hematospermia after starting that medication. I'll just briefly say, I doubt it's the medication that's causing the hematospermia. We really see blood in the semen, which is the term, the fancy name for is hematospermia. That really tends to be a benign process, meaning nothing concerning, nothing bad, and also a self-limiting process, meaning kind of as randomly as it starts, it can go away. But depending on your age and your other risk factors, important to talk to your urologist and see if there's other testing, PSA, ultrasound, digital rectal exam, etc., that might be helpful for you. Do either of you have anything else to add about kind of hematospermia or any relationship to that with tadalafil?
Definitely not related to the medication. Most common source is inflammation of the prostate. And rarely, I mean, there are unusual things like you can have stones in the ejaculatory ducts that can cause it. But again, by far, there are always benign reasons for it. It's nothing that requires or you should worry about that there's something cancerous going on besides.
Great, thank you. All right, it's 7:56. We've gone through the bulk of the questions, so I think this is perfect timing. I just wanted to bring everyone's attention to a quiz that we have for you to check your ED symptom score. So that's going to pop up on the screen right now, and we welcome you to take that, give you a little bit of an objective analysis of your symptoms and your erectile dysfunction. And then I want to just put up all of our contact information so that you have this available. Jot it down. Please reach out to us. We are all accepting new patients. We are all more than happy and excited to learn more about you and help you with your specific urologic concerns. Gentlemen, Dr. Sterling and Dr. Bernstein, do you have anything to add before we close out the session?
Have a good evening.
Yeah, thanks everyone. Hopefully you found this helpful. Cara, thanks for putting this on.
Yes, thank you, Cara.
Oh, it's my pleasure. Anytime. I love talking about this stuff. So I appreciate my fellow urologists joining us and all of you who are live on the call, and those of you who are going or are watching this after hours or just off of the website. So thank you, and please reach out if there's anything else we can do. Good night.
Good night.
Good night.